Hi, I'm Chao-Wei Hwang from the Johns Hopkins University School of Medicine and the Frederick Health Hospital. Today we're going to talk about treating in-stent restenosis of an Ostial RCA stent that protruded well out into the aorta. The patient is a 65-year-old man who had Ostial RCA PCI about 9 months ago at an outside hospital for exertional angina. He is a very active gentleman and did well for a couple of months, but unfortunately he gradually developed angina again to the point that he is now still having angina despite 3 anti-anginal medications. Nuclear stress testing showed a large area of inferior ischemia. His EF was normal, and naturally we were suspecting restenosis of the RCA. So on Cath, his LAD and circumflex were unchanged and had only mild disease. And here's the best that we could do for the RCA. The fellow could not cannulate the RCA, and I tried it. I could not do it either. But on this non-selective shot, you can see that there might be something going on at the ostium. And here's why we couldn't engage the RCA. If you go through the angio frame by frame, you see that the Ostial RCA stent is bent and sticks out well out into the aorta, at least 5 millimeters, if not more. Our catheter was just banging against the side of the old stent. Now, with a little luck, I was finally able to get this shot, still from the side, below the mouth of the stent. You see that there is clearly fairly significant stent restenosis, perhaps from stent recoil, which can be quite common at the ostium of the RCA. So what's our strategy? Should we just wire and stent through the side of the old stent? Well, this is typically what is done, but needs to be done carefully as there are cases of stent avulsion that have been reported. Or should we try harder to cannulate the mouth of the protruding stent? This is tough to do. The most common technique used to do this is called the double wire technique. Okay, so here is how the double wire technique works. It's a fairly slick and elegant technique when you can get it to work. The first step is just to get your guide to the side of the protruding stent as we have done. You then pass your wire through the side of the stent. Because your engagement is going to be tenuous, usually a slippery hydrophilic wire will work better. Hydrophilic wires will be less likely to kick your guide out. Once you have your wire fairly far down the vessel, you loosen your TUI and start to slide the guide up gently over the wire and redirect it closer to the mouth of the stent. The first wire will help stabilize your guide and allow you to manipulate it a little bit more easily. Once your guide is reasonably close to the mouth of the stent, you can attempt to wire the stent with a second wire. This step can be hard. I suggest wiring using a microcatheter to reduce the chance that your second wire will cross through another stent cell. Once your wire is within the stent cell, spinning the wire quickly with your fingertips can also help the wire avoid engaging another stent cell. Alternatively, you can also try bending your wire tip into a tight J. Once you're happy with the position of your second wire, you remove the first wire and pull the guide into the mouth of the stent and proceed with PCI as usual. So a nice, elegant technique and sounds great in theory, but for this particular patient, I simply could not get it to work. The second wire either would not enter the stent at all or just went through another stent cell. So I decided to just stent through the side of the ostial stent. So I already had a pro-water wire down. I did a first dilation with a 2.0 compliant balloon to stretch out the stent cell, and then pass a 3.5 millimeter compliant balloon that you see here. You can see that there is still a waste in the stented segment. And the waste finally yielded after very high pressure balloon inflation with a 3.5 millimeter non-compliant balloon. Now, a couple of tips here. The cases of ostial stent avulsion that have been reported involve the use of cutting balloons. So I would avoid the use of cutting balloons when stenting from the side of a severely protruding ostial stent. And for the same reason, make sure that your balloons are completely deflated before withdrawing. Remember that in a lot of cases, the protruding stent may only have a short segment that is actually within the vessel. So if you pull a cutting balloon or a partially deflated balloon, you could catch the bent and protruding segment of the stent, and then you could end up dislodging the stent completely. Okay, so here I am placing our new stent within the old protruding stent. I'm trying to make sure that the new stent spans the entire diameter of the protruding segment of the previous stent so that the RCA can be more easily cannulated in the future. I also make sure that the new stent ends well beyond the edge of the previous stent so that we minimize the chance that the ostial stent can dislodge. And notice how bent the old protruding stent is. The proximal end was essentially bent 90 degrees from its distal end. That's probably why we could not get the double wire technique to work in this particular case. And here we are post-dilating with a 5.0 millimeter NC balloon at very high pressure. I tried to stretch the ostial stent, the ostial end of the new stent as much as possible. And given the amount of intentional protrusion, I don't think an ostial flash balloon would have done much here. And here's the final angiographic result, which I thought looked very satisfactory. The patient went home the same day, and at the 2-week follow-up with his cardiologist, his angina was completely gone. All right, take-home messages. Ostial lesions are challenging to treat in general, and there are techniques to more reliably stent the ostium. I actually have a couple of videos describing these techniques on this channel. But sometimes it just doesn't work, and you end up either missing the ostium or protruding too much into the aorta. And restenosis of a severely protruding ostial stent can be incredibly difficult to treat, given difficulty engaging and difficulty wiring. We discussed the double wire technique. This elegant technique can help cannulate the mouth of a protruding stent, but if the protruding stent is too bent, as it was in this case, the technique may not work. We also discussed simply stenting through the side of the protruding stent. This is more commonly done, but especially in cases where the protruding stent has only a short segment within the vessel itself, remember to avoid cutting balloons. Make sure your balloon is completely deflated before withdrawing. And remember to make sure that your new stent completely spans the old stent, both proximally and distally. Thank you for watching.